In this lecture, we'll be discussing malaria in pregnancy. I'm Dr. Allen Olubukola, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. At the end of this lecture, I expect that you should be able to discuss the clinical and epidemiological significance of malaria and discuss the burden of malaria in developing countries. You should be able to understand and discuss the pathophysiology and peculiarities of malaria in pregnancy. You should also be able to discuss the clinical presentation of malaria in pregnancy and how to diagnose malaria in pregnancy. You should be able to manage patients who have malaria in pregnancy and also discuss prevention of malaria in pregnancy. Malaria is the most common parasitic disease in humans and is an infectious disease that is born and transmitted by the female Anopheles mosquito. Malaria is caused by infestation with protozoan parasites of the genus Plasmodium, and there are different species. The most common malaria infection and most virulent is caused by Plasmodium falciparum. Other species include Plasmodium vivax, Plasmodium malariae, ovale, and more recently, Imulese. Malaria infection during pregnancy is a significant public health problem, and as common as this disease is, it could be associated with significant risk for the pregnant women, our born fetus, and even the child after delivery. The symptoms and complications of malaria in pregnancy may vary in intensity according to the particular geographical area that's under discussion, and this could also vary according to the individual's level of immunity, and this will depend on how much malaria infection this patient has been, the person has been exposed to, and the immunity that she has acquired following repetitive infections. In highly endemic areas, the frequency and severity of malaria infection is higher in primary gravity, and this tends to decrease with increasing parity. However, in women who are not immune, the risk is similar across parity because either this is her first or her second pregnancy, this woman is naive to malaria infection. As such, the clinical presentation will be the same for both of them. The illness associated with malaria and other complications that could follow malaria, such as anemia in pregnancy, preterm birth, and low birth weight babies, are typically occur following infestation with Plasmodium falciparum, and this occurs predominantly in Africa. Maternal anemia is an important cause of morbidity and mortality in women, and malaria is one of the significant causes of anemia in pregnancy. Preterm birth and low birth weights, which are also complications of malaria, may cause problems in babies even after they are born. It could be associated with cognitive and cognitive development problems, and is also a risk factor for major neonatal and infant mortality. Malaria is also a significant cause of under 5 mortality in the developing world. So to briefly discuss the burden of malaria, data from the World Malaria Reports in 2019 showed that there were about 155 million estimated cases in malaria in 11 high-burden, high-impact countries, which are some of the countries that are most affected with malaria, and most of them are in Africa. And it shows that there was a slight reduction in the incidence of malaria, at least between 2010 and 2019. However, the Democratic Republic of Congo and Nigeria alone accounted for up 84 million of cases, which is more than half of the total number of cases. Of all these countries, Ghana and Nigeria reported the highest absolute increased cases in malaria in 2018 compared to 2019, and this just goes to show that the fight against malaria is still ongoing, and we need to take conscious efforts and continue the war against malaria in order to have improved outcome in the future. However, malaria deaths reduced from 400,000 in 2010 to about 260,000 in 2018, which means that even though the rate of malaria infestation is still increasing, there is reduction in malaria deaths. And the largest reduction was seen in Nigeria by almost 153,000 deaths in 2019 to 95,000 deaths in 2018. So, studies were also done to assess the uptake of intermittent preventive therapy for malaria in pregnancy. And it was shown that only countries such as Burkina Faso and United Republic of Tanzania were estimated as having more than half of their pregnant women receiving up to 3 doses of intermittent preventive therapy for malaria. However, in countries such as Nigeria and Uganda, the estimated coverage was only about 30% or less. So this diagram shows the burden of malaria globally, and this shows that the areas of highest prevalence and endemicity occur in sub-Saharan Africa, of which Nigeria is a part. So briefly discuss the life cycle of malaria and plasmodium infection. So the infection usually starts with when a mosquito which is infected with the plasmodium parasites bites a human being. So the mosquito takes a blood meal, and in the process of this deposits some of the sporozoites, which are resident in the salivary gland of the mosquito, into the circulation in a human being. And then following this, these sporozoites then are sequestered within the hepatocytes, which in the liver cell. So this sporozoites then replicates within the hepatocytes. And then after some degree of replication, they grow into schizons, in which the sporozoites then evolve into merozoites. So after repetitive cycles of replication within the schizons in the hepatocytes subsequently ruptures. So this rupture then leads to release of merozoites into the circulation. So this is the intrahepatic cycle, or also known as the exoerythrocytic cycle. So following this, once these merozoites are released into the circulation, then they infect red blood cells, also known as the erythrocytes, and this marks the beginning of the erythrocytic phase. So within the erythrocytes, there is replication of these merozoites into the trophozoite phase, also known as the ring stage, and then they also mature and form into schizons, and then there's these schizons also mature up to the point and replicates until the erythrocyte also ruptures. So once there's rupture of these erythrocytes, these ruptured schizons releases sporozoites into the circulation, and they go back and infect new hepatocytes, new erythrocytes. So this marks the erythrocytic cycle, and the timing of the rupture of these erythrocytes also coincides with the occurrence of fever in patients who have malaria infection. So this marks the erythrocytic cycle. So during this replicative process, some of these sporozoites that are released then go on, instead of reinfecting new erythrocytes, they go on to form gametocytes, and these are resident within the circulation. So these gametocytes lie in wait until another mosquito takes bites the affected human being, and as such, these gametocytes are taken up into the mosquito, and then this in the mosquito, then the gametocytes undergo the sporogonic cycle or the sexual cycle. That which occurs in the human is described as the asexual cycle. So within the mosquito, these gametocytes then evolve into macrogametocytes, eukaryotes, and then subsequently into oocysts, and these are what are resident in the salivary glands of the mosquito until the mosquito bites another human being, thereby spreading the malaria infestation. Another thing to note is within the intrahepatic cycle or the exoerythrocytic cycle, some of these merozoites within the hepatocytes, after rupture, they just stay within the hepatocytes instead of infecting erythrocytes. As such, these are called hypnozoites, and they stay resident within the hepatocytes. And these are some of the things that cause latent infection especially, and this is more common in species such as Plasmodium malaria and ovale. And this may cause recurrent infections in this category of Plasmodium species. So this just illustrates clinical syndromes that are associated with malaria. Malaria could cause acute disease, and in patients, especially in endemic areas or in patients who have had repeated malaria infections. This acute disease could be non-severe. It usually occurs as an acute febrile illness. However, in some cases, it may lead to severe malaria and ultimately death if not appropriately diagnosed or managed. And this could also occur in patients who are non-immune or who have their first exposure to malaria. They are at more risk of severe malaria and its complications and ultimately death. While chronic disease usually occurs in endemic areas, in patients who have had recurrent infections or chronic infection with malaria, they could have asymptomatic infections, and as such, people who are endemic to areas such as Nigeria may have chronic parasitization without any acute febrile illness. This may lead to complications such as anemia, especially in children and in pregnant women. In children, there could be complications such as neurodevelopmental disorders. There may be need for repeated blood transfusion, may also lead to death. In pregnant women, chronic infection is usually manifested as placenta parasitization, in which these parasites are sequestrated within the placenta, and this will lead to complications in the mother and the fetus, such as growth restriction, low birth weight, and could lead to increased fetal morbidity and mortality. So, malaria and pregnancy are two mutually aggravating conditions, such that the presentation and the management of malaria in pregnancy may be difficult or different from patients who are not pregnant. And the physiological changes of pregnancy and the pathological changes in malaria have synergistic effects on the course of each other. Malaria infection, especially that arising from Plasmodium falciparum, can run a turbulent and dramatic course in pregnant women. And women who are non-immune, such as women who just traveled to endemic regions from non-endemic regions, or primogravidae, which are women in their first pregnancy, are more susceptible to having severe infection of malaria in pregnancy. So malaria infection in pregnancy is typically more common than, so you find a woman who has grown up in an endemic region, who has had repeated infections with malaria, or however, once she gets pregnant, she has repeated malaria infections, which she might not have had if she was not pregnant. They are more common, they are more atypical, and they tend to be more severe. But that severe malaria could occur in women who are pregnant, in which such occurrence has not happened before. Malaria is more common in pregnancy because of the immunosuppression that is associated with pregnancy, and during the process of pregnancy, there is also loss of acquired immunity to malaria. So this makes these women more susceptible to infection. Presentation of malaria may also be more atypical because of some of the hormonal and immunological changes of pregnancy. And then parasitemia also is more severe. This may also be due to placenta parasitization. It could be more fatal as well because they are more at risk of having severe infection. And the mortality rate is said to be double in pregnant women as compared to non-pregnant population. Treatment in malaria in pregnancy may also be challenging because one, we need to consider the pregnant woman as a whole. We need to consider what gestational age is this woman presenting at. Some of the treatments or the medications that could be offered with this patient that could be used in women who are not pregnant cannot be used in patients, especially those in their first trimester. So this may make management challenging. Some of the things that also occur in pregnancy, such as nausea and vomiting, especially in the first trimester of pregnancy, may make treatment challenging as patients may be unable to tolerate whatever medications they are being prescribed. Then, so the pathology of malaria in pregnancy, as discussed, malaria can run a very turbulent course in pregnancy, especially in the first and second pregnancies, and from the third pregnancy onward, this effect is reduced. So some of the changes that are associated include changes in the hormonal milieu of a pregnant woman, increase in bodily fluids, decrease in hemoglobin level due to the physiological dilutional anemia of pregnancy, and this may also be complicated by malaria infection, which could further worsen anemia in these pregnant women. So the placenta is an important site in the pathophysiology of malaria in pregnancy, and is the preferred site of sequestration and development of the malaria parasites. So within the placenta, there is sequestration of these parasites, and the intervillous places are filled with parasites and macrophages. So this leads to a chronic inflammation at the level of the placenta bed. So this chronic inflammation leads to infiltration with inflammatory cells such as macrophages, also with cytokines, and this in the long run interferes with oxygen and nutrient transport to the fetus. There could also be villous hypertrophy and fibrinous necrosis of the villi of the placenta. And then there are also some malaria pigments called the mosaine pigments, which are also deposited in the placenta bed, such that even after the parasites have been cleared out, these pigments stay within the placenta, and this could also compromise oxygen and nutrient supply to the fetus. And this could then lead to intrauterine growth restriction and then low birth weight. Babies. So this is a broad classification of some of the signs and symptoms that could be seen in malaria. Patients who have acute malaria infection, they usually come with an acute febrile illness. There could be non-specific symptoms such as malaria, anorexia, nausea and vomiting. Patients may have fever. Typically they come with high-grade fever with shivering and chills and rigors. There are associated headaches, muscle pains and joint pains. Malaria could also cause uterine contraction in these patients. So some of them may come with false labor pains. So in complicated malaria, there could be signs of complications which may be varying, which could be seen, and malaria could affect any organ system in the body. So some of the complications that could be noted include dizziness, there could be difficulty in breathing, patients could be drowsy, there could be confusion, patients could also come comatose in severe cases, such as in patients that have cerebral malaria. So fever could occur in different patterns. There could be patients could be afebrile, especially patients who have some degree of acquired immunity to malaria. Patients will also come afebrile if they have been taking some medications or antipyretics at home prior to presentation. As such, one may still need to maintain a high index of suspicion. Fever may be continuous, could be low grade, and there could be hyperpyrexia. And the fever patterns may vary depending on the species of the plasmodium that's responsible for the malaria infection. However, most commonly, the Plasmodium falciparum malaria usually causes paroxysms of fever every 48 hours. However, this could range from occur every 24 hours up to every 72 hours. So one may still need to maintain suspicion in order to make a diagnosis of malaria in pregnancy. There could be more frequent paroxysms of fever in pregnant women as opposed to a non-pregnant woman due to the immunosuppression that is associated with pregnancy. Anemia is also an important thing that could complicate malaria in pregnancy, and when these patients come, they could be noted to be pale. They could also have symptoms such as dizziness or generalized weakness, which may suggest anemia in them. Anemia is a common feature of malaria in pregnancy, and there are in developing countries, there could be other confounding factors which contribute to anemia in these women, such as malnutrition, as a lot of people in developing countries are malnourished and have low socioeconomic status, so there could have been a background nutritional anemia. Then infestations such as helminthiasis may also cause anemia in these patients. So on examination, some of the other signs that could be seen include splenomegaly, then signs of complications such as acute pulmonary edema must be looked out for, such as difficulty in breathing in these patients. Patients could also have hypoglycemia, which may cause generalized weakness or even fainting spells. Patients may be jaundiced in severe cases in which is associated with hemolysis. Then in complications such as cerebral malaria, there could be convulsions, altered sensorium, or coma. So when one is assessing a pregnant woman with symptoms suggestive of malaria in pregnancy, one is to take this history holistically. If it's a patient who is coming, one would want to take a history of travel, especially if it's someone who is coming from an endemic area, from an area in which malaria is endemic. She could have acquired malaria infection prior to coming back home. Patients could also have extreme weakness, which is also called prostration, in addition to other symptoms that have been noted, such as fever, general malaria, and body pains. There could be abnormal behavior or altered consciousness when this infection is becoming severe. Then convulsions could be seen in patients that have cerebral malaria. And in this one, we want to take this history appropriately, identify the number of episodes, what kind of convulsion it was, in order to rule out other causes of convulsion in these patients. We also want to know what time she ate last, or took any food last, or had a drink last, in order to assess the risk of hypoglycemia in these patients. So in severe cases, malaria can also be associated with acute renal injury, and as such, a history of reduced urinary output is also important in this patient, at this with increased risk, suspicion of acute kidney injury. And then, apart from the volume of the urine, we want to assess what color is the urine. Is it normal colored? Is the urine dark or Coca-Cola colored? And this will depict hemoglobinuria, which is also a sign of severe malaria and occurs when there is hemolysis. And drug history is important in assessing patients with malaria in pregnancy, as patients might even have done some self-medication at home prior to presentation. So we want to know what medication she has used before she came, and what type specifically. And this will also help in making decisions in management of these patients. So then other differentials should be ruled out if there are other symptoms which suggest urinary tract infections or gastrointestinal symptoms. One would also rule this out, as this may also confound malaria in pregnancy. So on physical examination of these patients, a general physical examination should be done for these patients, and importantly, one wants to assess the level of consciousness. In patients with acute uncomplicated malaria, they typically would be conscious. However, in severe malaria, in which there could be complications such as cerebral malaria, there could be altered sensorium, or even unconsciousness in these patients. So the level of consciousness can be assessed using the Glasgow Coma Scale. However, in low resource settings, or in places in which there isn't appropriate knowledge, one can use this brief assessment called the AVPU scale, and this will help to know if this patient is alert or and communicating freely, or if she just responds to voice commands, if she only responds to pain, or if the patient is unresponsive. And this would also help to triage the patients and know what level of care this patient will need. Some of the other things that could be found include papilledema and retinal hemorrhages, which are also associated with cerebral malaria. The respiratory system must be assessed, as complications such as acute pulmonary edema or even metabolic acidosis might present with respiratory distress in this patient. So in making a diagnosis of malaria in pregnancy, of course, the history and clinical examination is very important in assessing these patients. However, the definitive diagnosis is made via parasitological examination or parasitological diagnosis of malaria. And this is typically done using the rapid diagnosis test or blood sphere for microscopy. The peripheral blood film for microscopy has been practiced for decades and is widely accepted. If this is to be done, and it still remains the gold standard for diagnosis of malaria in pregnancy. So we're making a diagnosis, a smear of blood, a sample of blood is taken from this patient, and one makes a smear on a microscope, and this is examined under a microscope. And this is divided into two parts. One will do a thick film and a thin film, and then the thick film is used to assess the density of the parasitemia, while the thin film is used to determine what species of infestation of Plasmodium is causing this malaria infection. So other modes of diagnosis that can be done include the rapid diagnostic tests, which are also more commonly used now in recent times. Most common of this is the antigen detecting test, which include the histidine-rich protein assay or the lactase dehydrogenase assay. The HPR2 is more commonly used, and the advantage of this is that it does not require as much skill to assess. So this can be easily done by taking a sample of blood and using the rapid kits, and this helps to tell whether my person is positive for malaria, Plasmodium infestation or not. So this can easily be done in the field. It helps us to make a diagnosis and offer treatment to patients rather than having to take a sample and send it to a lab where skilled personnel is needed. However, the downside to this is that one will not be able to ascertain the level of parasitemia appropriately in these patients. So other investigations that can be done include the antibody test. However, this is not routinely done currently for malaria assessment. Fluorescent in situ hybridization can also be done for diagnosis of malaria. Polymerase chain reaction based assay and placental blood smear are also other modalities that can be used in making a diagnosis of malaria. However, this may not be feasible for routine day-to-day assessments of women in the clinics or in the emergency departments for malaria, and they may be more applicable for research purposes. So other investigations that can be done, so these are ancillary investigations that would also be done in assessing patients for malaria, and different investigations may be done depending on the presentation of this patient. A hemoglobin concentration is important in these patients, as one wants to know this part cell volume and rule out anemia in these patients. A random blood sugar level should also be done in order to rule out hypoglycemia, especially for patients who are severely ill and who have not been eating regularly. In patients who are unconscious or who have altered sensorium, one will want to rule out differential diagnosis such as meningitis or encephalitis, and as such, a lumbar puncture for assessment of the cerebrospinal fluid may be important in this patient. Other investigations such as blood culture can be done in order to rule out sepsis, and then electrolyte urea and creatinine should also be done to assess renal function, especially in patients who have complaints of reduced urinary output. So the management of malaria in pregnancy may be challenging, and it involves different modalities. Patients will be assessed when they present, and patients with acute uncomplicated malaria could be treated as such as outpatient basis. However, patients with severe malaria may need further resuscitation. The malaria, then definitive treatment of malaria should be done, and then if there are any complications that are identified, this should be treated promptly as well in order to improve outcome in these patients. And the mode of modality would also depend on the gestational age in which this patient presents. So first, we will discuss the acute uncomplicated malaria, which, as earlier described, patients could present with an acute febrile illness, and there are no signs of severity of malaria, as will be elucidated later. So for women with acute uncomplicated malaria, the challenge occurs if they present in the first trimester. Within the first trimester of pregnancy, the recommended treatment for malaria in pregnancy includes oral quinine and clindamycin. And oral quinine can be administered 600 milligrams orally for 7 days with clindamycin. However, in the absence of clindamycin, the complete course of oral quinine can be used, and one would ensure that the patient completes this. This is because oral quinine has been found to be safe in all trimesters of pregnancy. And however, in the second and third trimesters, the preferred line of management include artemisinin-based combination therapy, of which the most commonly used includes artemether and lumefantrine. So in patients that present with acute malaria or complicated malaria, these can be used to manage these patients, and they are successful. In women who are lactating also, artemisinin-based combination therapy can also be used successfully to manage malaria in these patients. The drawback to using oral quinine, especially for patients in the first trimester, include the fact that the pill burden is high, and patients find it cumbersome completing these medications for 7 days. Quinine may also be associated with complications such as hypoglycemia. So as such, in patients who are on this medication, one is to counsel them appropriately and ensure that they are monitored in order to prevent these complications. So severe malaria in pregnancy may be challenging, as the presentation may be diverse, and there are different conditions that could be associated with severe malaria, or which would account for a diagnosis of severe malaria. So in the presence of P. falciparum parasitemia, any of the following would count for a diagnosis of severe malaria, and this includes impaired consciousness, such as a Glasgow Coma score of 11 or less than 11 in adults. When there's prostration, which is described as generalized weakness, such that the patient is unable to sit, to stand, or walk without assistance. When a woman has multiple convulsions, more than 2 within 24 hours, associated acidosis, hypoglycemia, anemia, any evidence of renal impairments, evidenced by plasma or serum creatinine, which is elevated, presence of jaundice or hemoglobinuria, which suggests hemolysis, and this will also be evidenced by raised serum bilirubin levels. Pulmonary edema, also as described earlier, could be a major complication of malaria, of severe malaria, and these patients could present with difficulty in breathing, and there could also be decreased oxygen saturation. Patients may be tachypneic with in obvious respiratory distress with chest indrawing and crepitations on auscultation. Then in severe cases, malaria could also be associated with complications such as disseminated intravascular coagulopathy, and this could present as significant bleeding from different sites. Patients could have bleeding from a nose, gums, or venipuncture sites. There could also be hematemesis or melena. Patients could also come in shock, which could be compensated or decompensated. And then on parasitological examination, the presence of hyperparasitemia, even in the absence of all those clinical signs, which is described as a parasite density of 200,000 or more parasites per microliter of blood, is also confirmed the diagnosis of severe malaria. So women with severe malaria must be treated. The diagnosis must be made promptly and must be treated aggressively in order to prevent or forestall any complications that has arisen. And the gold standard for management of severe malaria in all trimesters of pregnancy is intravenous artesunate for at least 24 hours. So once the patient has received 24 hours of parenteral artesunate therapy, then this must be complicated with oral artemisinin-based combination therapy. However, if she's unable to tolerate this after 24 hours, then one will continue with artesunate until the patient is unable to tolerate orally. If artesunate is unavailable, or if there are any other contraindications to its use, other options include the use of intramuscular artemether and intravenous quinine. So intravenous artesunate is administered at a dose of 12.4 milligrams per kilogram body weight, and this is given within the first 24 hours at presentation, 12 hours after, and 24 hours from presentation, which is 3 doses within 24 hours. And then this will be continued at a dose of 2.4 milligrams per kilogram body weight daily until the patient is able to tolerate orally, after which this is changed to oral artemisinin-based combination therapy. However, if artesunate is unavailable, then intramuscular artemether can be administered, and this is given as with the starting dose of 3.2 mg per kilogram intramuscularly at admission. Then following this, one will give 1.6 mg per kilogram body weight daily until the patient is also able to tolerate orally. And after this, then this regimen must still be completed with artemisinin-based combination therapy. In the absence of these two, intravenous quinine may be administered, and this is given as intravenous quinine 20 mg per kilogram body weight at admission as a loading dose, and then this is given as an infusion over 4 hours. Then maintenance dose will be given at 10 mg per kilogram body weight every 8 hours. So this will be done until the patient is also able to tolerate orally, following which it will be converted to oral quinine, and then the patient will be given enough to complete the total 7-day dose. So having said all this, some studies have been done recently assessing, in sub-Saharan Africa, assessing the efficacy and the risks of managing artemisinin-based combination therapy to quinine. And it's shown that for women who had been on artemisinin-based combination therapy, who were on it before they got pregnant, or who used it inadvertently before they knew that they were pregnant, ACTs were not shown to be associated with any increased risk of miscarriage, stillbirth, or pregnancy loss. However, data is still limited enough to in order to make ACTs a gold standard for management of malaria in pregnancy. So as such, it is recommended that for women who are unable to tolerate oral quinine, or in which oral quinine is not available, one may still use artemisinin-based combination therapy to manage malaria in pregnancy in all trimesters of pregnancy. So this is just a clarification of the common types of anti-malaria drugs that are available, and there are different classifications. The pharmaconolones, more especially chloroquine, was used in popularity previously. However, because of the advent of resistance to this drug, its use has been diminished. However, more commonly used now include the artemisinin derivatives, and then the others such as the antimetabolites are also used in different combinations in order to manage malaria in pregnancy. So this just shows the different available medications divided into those who are which are safe in pregnancy, such as chloroquine, quinine as discussed. The pyrimethamine and sulfonamides are also safe in pregnancy, but are used more commonly in the second trimester of pregnancy. One would want to avoid using pyrimethamine in the first trimester of pregnancy because it's an antifolate and as such may cause neural tube defects. So, however, they are safe for use in second and third trimesters of pregnancy. Okay, so these are some of the drugs that are contraindicated in pregnancy. So I'll briefly discuss some of the complications of malaria in pregnancy. Anemia is an important complication of malaria, as earlier discussed, and this could be due to, it could arise following hemolysis of parasitized red blood cells. There are also increased demands in pregnancy. The profound hemolysis may also aggravate folate deficiency. And in women who are pregnant, especially in the first trimester, they could have nausea and vomiting in pregnancy. This may prevent them from having adequate oral intake, and as such, this may put them at increased risk of having even a background nutritional anemia, which may be complicated by malaria infestation. Then it's also seen that following malaria infestation, there are also deposition of some of these pigments as deposited in the placenta. These pigments, called the mosaic pigments, may also be deposited within the bone marrow, and this causes suppression of production of red blood cells, and this may also lead to anemia in these women. Anemia is said to be more common within 16 to 29 weeks of pregnancy, and it may develop suddenly, especially when parasitemia is high, and associated with increased perinatal morbidity and mortality, increased risk of complications such as pulmonary edema. As such, also risk of postpartum hemorrhage is higher, and the transfusion of red blood cells may be necessary in order to manage this. Acute pulmonary edema is another complication that's not commonly seen in non-pregnant patients, but may complicate malaria in pregnancy, and is more common in second and third trimesters. It may also occur immediately postpartum due to an autotransfusion of these placenta red blood cells following delivery back into the circulation, and then also there will be an increase. There's an increase in peripheral vascular resistance after delivery, and this may place these women at more risk of acute pulmonary edema, and is associated with very high mortality. Hypoglycemia could also be seen in these women, as been discussed earlier, and this may be due to increased demands in pregnancy. Pregnant women also have an increased hypoglycemic response to starvation. So, and this could also arise following some of the drugs that are used to treat malaria, such as quinine. So, as such, one must always be on the lookout to diagnose and to prevent, diagnose, and treat hypoglycemia in pregnant women. So, some of the complications that may be seen in the fetus could be associated with high-grade fever. It could also be associated with placental insufficiency from the chronic inflammation at the placental bed, as earlier discussed. Hypoglycemia in the mother could also affect the fetus adversely, and then anemia, in maternal anemia, may also lead to complications in the baby. So some of these complications include increased risk of spontaneous abortion, which may be more common in the first trimester. In second and third trimester, early third trimesters, there is an increased risk of preterm labor, preterm contractions, which may lead to preterm labor. There may also be preterm death and preterm birth and its attendant complications. Malaria may also cause intrauterine fetal demise. It may cause stillbirth. It may cause placental insufficiency, which may be complicated by intrauterine growth restriction and low birth weight and fetal distress. So these are some of the complications that may be seen in fetuses of women with malaria in pregnancy, especially recurrent infections. Briefly, we'll talk about the complications of malaria in pregnancy and how this can be managed. So in patients who comes, apart from all their resuscitative measures that have been discussed and the anti-malaria medications that should be instituted. These are some of the extra precautions that should be taken in some of these conditions. So in a patient who comes in a coma or who is unconscious, one would want to ensure that the airway is patent, ensure suctioning as necessary in order to prevent aspiration of these patients, and then ensure that she is having adequate oxygenation. And a nasogastric tube may be necessary in order to feed these patients. And one needs to monitor these patients and prevent hypoglycemia, and this may be corrected or prevented by administering dextrose-containing fluids. So in patients who have cerebral malaria assisted with convulsions, we also want to ensure that the patient is safe and prevents people who are around from further complicating this by local practices such as putting a spoon in the patient's mouth or preventing this patient from burns or injuries during the convulsion. After this is done, we want to ensure this patient's airway and that she's breathing. Then if there's any hypoglycemia, this should be corrected. Convulsions could be aborted using intramuscular or intravenous diazepam. In patients who come in dehydrated or with shock, prompt resuscitation must be done with normal saline at a rate of 20 to 30 milligrams per kilogram, and then patients can be reassessed in order to assess the need for further fluid derangement. Severe anemia may necessitate transfusion with plaqued red blood cells, and this should not be withheld with patients if indicated. Patients with pulmonary edema may need intravenous furosemide in order to to encourage excretion of fluids, and this patient may also be nursed in cardiac position, and then strict fluid input and output monitoring will be done for this patient. Okay. Acute kidney injury may also complicate severe malaria in pregnancy, and these patients must be appropriately monitored. Fluid restriction should also be given for these patients, and if the patient still does not make urine, then one would also need multidisciplinary approach by inviting nephrologists to review the patient. In severe cases, patients might need hemodialysis in order to prevent further complications. So differential diagnosis of severe malaria include meningitis, especially, and this will be considered in patients who have cerebral malaria. However, in meningitis, patients may have neck stiffness, which will be absent in malaria. Encephalopathy encephalitis or encephalopathy may be associated with repeated convulsions or a deep coma, which does not resolve despite all the anti-malaria or resuscitative measures. Patients with sepsis usually are very ill and toxic and may have warm extremities. However, a blood culture would help in making a diagnosis for these patients. Then other differentials include diabetes mellitus, in which patients may come dehydrated or ketotic. Viral hemorrhagic fevers are an important differential and must be considered in patients who have had repeated fever, which does not abate with the use of anti-malaria. These patients may also have a history of bleeding and jaundice. So this must maintain high index of suspicion for these conditions. COVID-19 infection is also a differential diagnosis for patients with malaria in pregnancy, and this may be associated with respiratory symptoms such as cough, shortness of breath, and respiratory distress. So now, the prevention of malaria is an important topic, and discussion of which cannot be overemphasized. Prevention of malaria would help to prevent all these complications which could be seen in both the non-pregnant and pregnant complications and even the unborn babies. So vector control is very important in prevention of malaria because, as discussed, malaria infestation is transmitted via the female Anopheles mosquito. So if one is able to control these mosquitoes and prevent them from biting human beings, this will help to prevent or limit spread of malaria. So this can be done by the use of long-lasting insecticide-treated mosquito nets, and it's advocated that every person, especially those who reside in endemic areas for malaria, should sleep under insecticide-treated mosquito nets, and this will help to reduce their risk of developing malaria infection and its complications. The use of insecticides also within the house can be done, and this can be done intermittently. Insecticides are readily available, and this can be easily procured. So one can use insecticide sprays within the house in order to kill any vectors that could be resident within the house. Indoor residual spraying is also another mode of malaria prevention, and this involves spraying the walls of the house with insecticides, and this lasts longer and prevents these vectors from dwelling within the house, and prevents malaria infection. Intermittent preventive therapy for pregnant women is an important part of prevention of malaria in pregnancy, and this is done using by administering anti-malarials to pregnant women, asymptomatic pregnant women, in order to clear any presumed malaria infestation, and this would help to prevent the incidence of acute malaria infection illness in them, and also help to clear or prevent malaria parasitization, and then lead to increased better outcome in both the mother and the baby. Seasonal malaria chemoprevention has been recommended in some areas, and this mostly applies to endemic areas, and this involves the administration of anti-malaria drugs. This can be administered monthly, and some of the drugs that can be used include mefloquine and also sulfadoxine pyrimethamine, and this involves the use of administration of these medications during the time where there is peak rainy season, which is during which in this time there is peak incidence of malaria illness. So this can be administered monthly to populations at risk, and this involves children, especially in the under 5 population, and also in pregnant women. There are studies currently being done on malaria vaccine, currently being piloted by the World Health Organization, and these are still undergoing trials. However, hope is they are working on a malaria vaccine is being worked on, and if this passes trials, then malaria vaccine may be administered in order to prevent malaria infection. So the intermittent preventive therapy for malaria, I'll briefly talk about this. It involves the use of sulfadoxine pyrimethamine, and it's briefly the administration of anti-malaria drugs at therapeutic doses to asymptomatic pregnant women at predetermined intervals in order to clear a presumed placental parasitization and then prevent complications of malaria in pregnancy and beyond. So this is done using sulfadoxine pyrimethamine, and it typically comes in a fixed dose combination in which one tablet contains 500 milligrams of sulfadoxine and 25 milligrams of pyrimethamine, and 3 tablets are administered, giving a total dose of 1,500 milligrams of sulfadoxine and 75 milligrams of pyrimethamine. And this should be administered as directly observed therapy. That means that this should be administered to pregnant women in the clinic, and they should take the medications while under observation. So the first dose should be administered as early as possible in the 2nd trimester, and the minimum of 3 doses should be given throughout pregnancy. However, each dose must be given at least 4 weeks apart. In some women who are HIV positive and are also on cotrimoxazole, or more commonly known septrin chemoprophylaxis, who take this daily, they do not need to take sulfadoxine pyrimethamine, as they have similar mechanism of action, and this will also help to prevent malaria in this patient. So this category of women should not need intermittent preventive therapy with sulfadoxine pyrimethamine in order to avoid sulfonamide overdose. Another category of patients in which one may withhold this sulfadoxine pyrimethamine therapy include patients who have hemoglobinopathies, in which who are on daily dose of progranil, and in these patients, the daily progranil they are taking will be sufficient to prevent malaria infection in them. As such, they do not need intermittent doses of sulfadoxine pyrimethamine and should be managed appropriately. So in conclusion, malaria in pregnancy is a condition of serious public health significance, and prevention and adequate case management is important in the control of this condition because of the prenatal and neonatal morbidity that could be associated with it. So all health workers should be conversant with the current trend in the management of this condition in order to prevent any complications that may arise. Prompt education and referral of severe cases will reduce maternal and fetal morbidity and mortality associated with pregnancy. So the references, thank you very much for listening.